Okay, good morning, good afternoon, depending where you are. It gives us great pleasure at Pallium Canada to be bringing you our first national webinar series focused on personal support workers. This webinar is the first of 3 in the series and is focused on the critical role PSWs play in the provision of palliative care. Next slide, please. Before we begin, I would like to take this opportunity to acknowledge the land in which I'm speaking to you from, which is the city of Ottawa. And the city of Ottawa is on the traditional unceded and unsurrendered territory of the Algonquin and Anishinaabe people. The Algonquin peoples have lived on this land since time immemorial, and I acknowledge the historical oppression of lands, cultures, and the original peoples in what we now know as Canada, and fervently believe that the work that we do collectively in palliative care can contribute to the healing and the decolonizing journey that we all share together. And we're grateful to have the opportunity to be present in this territory. And a special thank you to the Canada Council for the Arts for this acknowledgement that was developed by members of the Algonquin community. Next slide, please. Okay, so as I mentioned right off the top, this is the first in a series of webinars dedicated to PSW. It is a national ECHO session and part of the Palliative Care ECHO Project that Pallium Canada has the opportunity to lead here. And as you can see on the screen, the Palliative Care ECHO Project really is focused on being a capacity building telementoring program. It's designed to create virtual communities of learners by bringing together folks like yourselves and our presenters, local healthcare providers, community leaders, with regional, provincial, territorial, national subject matter experts for training, for deep dive learning opportunities, brief lectures, quality improvement discussions, fostering this all learn, all teach approach. So we're delighted to be leading this project. And if you want more information about the Palliative Care ECHO Project, please visit echopalliative.com, the URL being on your screen there. Next slide, please. I would like to acknowledge the financial support given to this project by Health Canada. So Health Canada is a funder of Pallium Canada and is a key contributor to the Palliative Care ECHO Project, and we'd like to recognize them. This whole initiative is made possible from their contribution. However, the views expressed herein don't necessarily represent the views of Health Canada. Next slide, please. Okay, so by way of introductions, my name is Jeffery Moat. I'm the Chief Executive Officer of Pallium Canada. I won't bother going over any of the housekeeping items. I believe Diane's going to be going through that, but I would like to provide the opportunity before I talk about conflicts of interest. I'll hand the floor over to both Diane and Tracey to introduce themselves.
Hi, everybody. I'm Diane Roscoe. I'm also speaking from Ottawa. We've got a wet, warm and steamy day here. I'm in the world's smallest office. At the beginning of the pandemic, I converted a closet into a very tiny office. It's working well for me. So I won't say anything other than what's in my, on the slide deck there about myself, but I want to just acknowledge that I'm a huge fan of personal support workers and I always enjoyed working with them.
My name is Tracey Human. Welcome, everyone. I'm coming to you from Toronto, Ontario. Some of my credentials are there on the slide deck. I don't want to take up the time we get to share with you by reading those out, but I'm very happy to be here today, and particularly with PSWs throughout the 40 years of palliative care practice that I've had the pleasure of. PSWs are some of my favorite people. I've learned many things from PSWs, and I'm welcoming you all, and I'm really looking forward to highlighting your critical importance in the palliative approach to care.
Wonderful. Thank you both Diane and Tracey for those introductions. In terms of conflicts of interest, first off, Pallium Canada is a national nonprofit organization. It was founded back in 2000. It's based here in Ottawa, funded, as I mentioned before, in part by Health Canada. Our role is to equip healthcare professionals, healthcare organizations, communities with the skills and the knowledge and the information to provide palliative care earlier, more effectively, and more compassionately to all Canadians. In terms of conflict, I'm an employee of Pallium Canada, and Diane and Tracey, would you like to speak to any conflicts that you may have?
Sure, mine are just what's on the slide deck there. I'm a paid LEAP facilitator and I have had the opportunity to develop LEAP courseware.
And mine are the same. I have been a paid LEAP facilitator and content contributor for the Pallium PSW material.
Wonderful. Thank you both. I will now hand the floor over to Diane.
So welcome everybody. You're welcome to introduce yourself in the chat. You've probably seen that you are muted, but feel free to run your video. We'd be delighted to see you. So there are times during the session where you're going to be able to unmute yourself, and so you can raise your hand to do that and we can call on you to make a verbal comment. Otherwise, if you're not comfortable with doing that, you can put it directly into the chat. So just a reminder that this session is being recorded and you'll get it by email in the next week or so. So next slide. So this is, as Jeff said, a three-part series. So we're today talking about the role of the personal support worker in palliative care. In July and August, there's 2 other sessions with dates to be determined. This LEAP personal support worker Q&A is going to be held in July, and that is going to be particularly interesting for those who have completed or are going to complete LEAP PSW. And in August, we're going to have a third session, and it's challenging conversations in the context of those individuals and families living with a life-limiting illness. Next slide, please. So we just have a couple of fun polls to start off with. So this is a nationally held program today, but we kind of want to know where you're employed or volunteering. So you've got the poll there on your screen. So if you can just vote on the place of employment or volunteering area that best speaks to where you're employed or volunteering. And just while we're voting, if anybody has any technical difficulties that you're experiencing, you can put that in the chat because the session is being monitored and we do have some support in that regard today. No, I cannot see the poll results. I can just see the poll.
Hi there, I'm from the support desk. I'm just going to step in and let you know what the poll results are. So it looks like the majority of people responding are from community home care setting and long-term care setting. And down from that, some people joining us from working from retirement homes and other. So those are the majority of people joining us today. Also some people from the acute care setting, hospice setting, and supportive housing.
That's great. So we've got a real variety. That's fantastic. So next slide, please. So this is a fun icebreaker slide. So all of us at some point will retire. Many people I know that retire fully for maybe a couple of years, and then they kind of look like for that fun job. So when you guys retire for your fun job, these are your only options. So we'll launch this poll. So you can be that food sampler at a grocery store where you sort of like, you know, engage somebody to come in and try that new and unique pate, a greeter at a large department store. You can be a professional clown for children's birthday parties, or maybe adults, I don't know, a makeup artist, or you could drive a mobile ice cream truck driver. And just last night, somebody told me that here in Ottawa, there's a mobile wine truck that moves around. I'm currently trying to scout its location. I think that's a great business opportunity. Why didn't I think of that? So I'll let Pallium launch that one. So we've got a big variety here Oh my gosh, nobody wants to be a clown. All right, that could be a whole, psychological issue there. I'm not sure. Thanks everybody for participating in that. That was kind of fun. All right, so I won't spend very much time on this slide, but here's our learning objectives for this 1 hour session today. So Tracey is going to guide us through the palliative care and the palliative care approach. Together, we're going to understand the role of the PSW in palliative care and how they fit into and are very important members of the palliative interdisciplinary team. And then we're going to apply the PSW in the delivery of palliative care to a case study. All right, Tracey.
Thank you, Diane. So one thing I want to call attention to here is the unusual image represented on our slide for palliative care. It's not a typical image that I would think that most people would think associates with palliative care. It depends on how fluent you are with the definition, because it's incredibly appropriate when we dive further for those who might be newbies, just need some more foundation of what palliative care is and the palliative care approach. I think as we go through this, you'll see that that image is incredibly applicable and appropriate. Next slide, please. There's a few questions that we want to kind of get, a temperature from you. And if you could put your responses in the chat, that would be great. What is palliative care? Really like to hear your voice and your opinions of what that is, or what you've learned it is. So while you're putting your responses in the chat around how would you define palliative care, what it is, I'm going to add the next question in. Who is palliative care for? Those who would like to chime in and put their information, their opinions, or
So
what they know of the model.
So we've got 5 comments coming in.
And when do you think palliative care should start? What are you seeing there, Diane, as the trending?
I'm seeing lots of good comments. End of life care aimed at reducing suffering, aiding with comfort and ensuring a smooth transition, a start for dying patients and families, holistic care.
Yeah, it's very true. And I think that many of the responses is very much what we expect to see and hear. We're going to actually expand what some of those ideas are around what palliative care is. So let's dive in a little bit deeper so we can all have our foundation well laid and firm. We'll go to the next slide. Palliative care is actually an approach to care that improves the quality of living for patients and their families facing the problems associated with life-threatening illness through the prevention and relief of suffering by means of early identification, impeccable assessment, and the treatment of pain and other problems associated with physical, psychological, and spiritual. I want to highlight a few things here. That's a definition. I want to pull out some points here. When we talk about it's an approach to care, so palliative care is how we go about caring for individuals. You'll see here that it's about that it improves the quality of life. A lot of people think that palliative care is about dying, and in fact, it's about living. It's about living until that moment when death occurs. Death is a moment in time. Until that, we are living. We're living with the illness as it progresses. We're living with the burden of that. Eventually, the body does start to succumb to that life-limiting illness burden. And in that moment, there will come that time when death occurs. but it's about living until that moment. It's for the individuals and their families. You know, healthcare tends to often focus on the individual who is the direct recipient of the healthcare, whether they're referred to as patients, individuals, residents, clients. And we forget that family actually walks that exact same journey with their loved one. It's hard to love and care for someone and not be impacted by their illness and watching their deterioration, whether that's over hours or days, whether that's over years, right? So in our palliative approach to care, our focus is on the individual and the family at the same time. They're one unit that we don't try to separate. It's about problems, needs associated with life-threatening illness. You may actually hear palliative practitioners call that life-limiting illness, because with the chronic progressive life-limiting illnesses, if the individual didn't have that, they would be expected to live longer. But because they have a life-limiting illness, their time with their loved ones and their community and society, etc., shortens. So it's life-limiting illness. Now, for some, that may be months to less than a year. And for some, depending on that life-limiting illness, it can be decades, right? So when we're thinking about life-limiting illness, we're thinking about people with organ failure. We're thinking about people with Alzheimer's, with ALS, Parkinson's, Huntington's disease, COPD. The list goes on. We're going to talk a little bit more about that. We talk about, nope, I'm almost done. I'll ask for the next slide. Please, can we go back? Thank you. It's about the prevention and relief of suffering by means of early identification. In this, of course, we want to identify everything early. Without identification early, we're late. And what you may not see there is PSW. When we talk about early identification, that's you. That's you. We could just insert by PSWs in that definition. And it's about impeccable assessment. All assessment starts with observation. Does that ring a bell? Whose skill set is about observation? Again, that's you. And when we talk about a holistic approach, we're not just talking about caring for the physical. So we'll go on to the next slide, please. This is a diagram of what we've been talking about. So palliative care is not just about dying, and it is not just about end of life. When you look at this diagram on the left-hand side, it talks about the focus of care. People start to experience symptoms before they actually get the diagnosis. At the very least, once they're diagnosed with that chronic progressive, life-limiting illness, the focus is about slowing that progression. Chronic by nature means it's not something that can be cured. Some things can be cured and some forms of cancer can be cured, but it's not just about cancer. So the aim is to modify, and as time, that illness experience, control those symptoms, slow down the progression of illness. Palliative care approaches there, whether it's restorative, whether it's rehabilitative, the hallmark is if they have a life-limiting illness. As time progresses and their illness journey evolves and the body starts to succumb and they functionally decline and they may have cognitive changes and their pain and symptoms start to evolve and change, the focus may become more and more palliative care, but it's there right from the beginning, from the time of diagnosis, all the way through the chronic and advanced stage of illness into the end of life care phase, where it becomes the sole focus. And then you'll see there that it goes on past the death of the individual to learning to live with loss, not only for the family, but for the team as well. because we're in there, we're experiencing that journey. When you care, you will feel. And we grieve and we carry those stories with us as we move on to care for the next. So it's about team and self-care as well. We'll go on to the next slide. Thank you. When we talk about the palliative care approach, which is simply the best possible care that we can give to individuals with chronic, progressive, and life-limiting illnesses. And when we talk about holistic care, we talk about what you'll see here on the left side. Those are called our 8 domains of issues. Those are the little houses where needs develop for individuals who are living with these life-limiting illnesses along their whole illness journey, from the first presentation of symptoms to the diagnosis, all the way through that illness journey towards the downturn towards end of life and death. And you begin to see here that it's about the disease management, the slowing of progression. It's about pain and symptoms in the physical, as well as nutrition and other things. The psychosocial, spiritual aspect is there. The practical needs flowing into the end-of-life care, death management, and the loss and grief. At the center of it is the individual and the family. When we look over on the right side, what we see there is our norms of practice. It's 6 steps. Those norms of practice is the way we go about delivering the care. It's from observation, that's you, with the layering on of the rest of the interdisciplinary team for their assessment scope. It's the information sharing. It's how we talk with the individual, the family, how we talk across the team for that continuity of care, for the care planning, for the treatment decisions, the healthcare consent, moving on to that direct care delivery from your brain through, and your skill to your hands, because you're often the ones that are with them the longest and know them the longest as our PSWs. And then we're confirming that what we are doing is meeting their needs and it's working, and we repeat it multiple times in our shifts, multiple times in the visits that we're making with these individuals, all the way throughout the whole journey. So this is our foundation of our palliative care approach, and you'll begin to see it's what you do every day. Let's go on to the next slide, please. Palliative care is active care. The palliative care approach is a highly active care approach. What I think a lot of people confuse is we use the term active care to mean curative. But I would ask you, for those of you that are involved with individuals who have advanced illness in the community or in long-term care, when they come in through emergency or admitted to complex continuing care in hospitals, would you say the care that you're delivering isn't active? Of course not. All care is active. So I want to make sure that we understand that active care can sometimes be used not to the best of how I like that term translated, because all care is active care. So active care should not be confused with meaning only curative, because the majority of individuals with life-limiting illness, when we're not talking about cancer types, over 72% of them have chronic progressive life-limiting illness where we never had the ability to cure. Our goal is to slow down that progression of that illness. So palliative approach to care may be curative in some instances. It's not curative in all instances. And it's certainly not the soft option where people might hear the phrase, there's nothing more we can do for you. Oh, yes, there is. We want to do all the way through and after, right? It's about living. It's proactive, it's needs-based, it's family and person-centered. It's appropriate for anyone at any age and all life-limiting illnesses. Now, when we say age, we're not only talking about children who are ill and have life-limiting illnesses, right? It can be throughout a woman's pregnancy. It can be her during pregnancy. It can be for the infants, the children, for the teenagers. It all depends on who is living with life-limiting illness, all the way through our elderly and those who have these life-limiting illnesses. And it takes a team, an interdisciplinary team where every role is equally as important. It's just, the role is just different because we all bring our knowledge, skill, and what we're there to zoom in on, and then we add that all together so there's no holes or gaps for individuals to fall through. So palliative care is not just about end-of-life care. It starts most definitely at diagnosis of those life-limiting illnesses, and actually is there when they have the symptoms, and it carries all the way through, and that can be for months or decades. It's not just for people with cancer. And this is something I really want us to be, each one teaching one, is people are not labeled palliative. Palliative is an approach to care. So the individual is not palliative. The approach to care and the needs that we're responding to may be described as the palliative care approach, or they have needs that the palliative care approach can meet. But an individual is not palliative. They're not deemed palliative. Those are not labels that we should be giving to an individual. Okay, we'll carry on to the next slide. We're going to watch a video here. It's going to pull and add a little bit more flavor in here to give you some more summation of what I was just talking about. You want to click on the magical link and we'll go in and we'll watch the video.
What comes to your mind when you hear or see? What comes to your mind when you hear or see the word palliative? Many people, appropriately, think of words such as compassion, dignity, or quality of life. However, for many people, what comes immediately to mind are the words dying, terminal, and end of life. Unfortunately, too few people think of palliative care alongside treatments to control the disease.
I'm Dr. Gordon Giddings. I'm a palliative physician at the University of Ottawa and clinical content editor of Pallium Canada. The aim of this Pallium Doodle is to explain that palliative care is not something for just the last days or weeks of life, but should be initiated much earlier.
To better understand this, let's look at the illness trajectory, starting at the time of diagnosis of a life-threatening illness. In some cases, the disease, whether it be cancer or another non-cancer disease, can be cured with treatments. In other cases, however, the disease may be incurable. Let's draw a graph around this journey. On the x-axis is the length of that journey from diagnosis to death. On the y-axis is the goals of care, the treatment and care options in focus. Now, unfortunately, because people often think of palliative care only for the last days or weeks of life, they will only activate a palliative care approach in the last days or weeks of life. Let's look at the negative consequences of this. They include lack of symptom control with unnecessary suffering, inappropriate treatment choices, prolonged psychological distress because no one is addressing the fears and concerns of the patient, lack of discussions about prognosis, or lack of preparation regarding care choices and treatment goals. So what do we need to do? Well, we need to erase the old model of palliative care and use a different model, a different approach. What if we start palliating early in the illness? This does not mean that treatments to control or cure the disease and palliation and supportive care are mutually exclusive. The model of early palliative care is much more patient-centered and responsive to patient needs. Is there evidence to show that early palliative care is better than late palliative care? In a large US-based study, by Timmel and colleagues, the model of early palliative care was compared to the usual or common model of palliative care, only in the late phase of disease. What do you think the results were? Which group do you think did better? Which group had less depression and less anxiety? Which group had better quality of life and symptom control throughout their illness? Which group do you think lived longer? The early palliative care group experienced significantly less depression and anxiety, better quality of life, better symptom control, and astoundingly, they lived almost 3 months longer than those patients who received only late palliative care. So the key message is palliative care early is better than palliative care late.
Well, welcome back from the video. You can certainly go on the Pallium YouTube channel and watch that again to help refresh what the palliative approach to care is. I'm just going to quickly cover this diagram here because what you hear us saying over and over and over is palliative care needs to be involved, our approach needs to be involved early rather than late. Because when we're late, there's all kinds of negative consequences for the individual, their family, the healthcare team. It becomes crisis management versus quality care delivery. And so there are warning signs that tell us that we're getting closer and closer towards transition points or destabilization of illness, or in fact, are that downward journey. I'm not going to take the time to go in to explain each one of these today. It's kind of a good prep for those who will go on to take the LEAP PSW. I'm mindful of the time, and I want us to move into the role that you serve and how important your role is. But when we're thinking about there's warning signs, there's these observations that tell us where people's journeys are going, that they are going to come down to a dip, or they're going to have a plateau, or they're going to destabilize. This is our PSWs. Research has been done, and anyone who has had the pleasure of working closely with PSWs know that it's the PSWs who catch these warning signs first. This is why we're here celebrating PSWs and wanting to build on the knowledge and skill and expertise you already possess. Next slide, please. So when you think of the illnesses that you see in the people you're caring for, which dying patterns or illness journeys is it that you might see in the people that you're working with? That's excellent. I'm seeing the poll there, and the physical and cognitive frailty. There's our elderly and or medically complex. That would fit in not only with our individuals in retirement homes or long-term care, but in community congregate settings, are people with intellectual and developmental disabilities, CPP, CP and the like, or organ failure. That's probably a lot in our community and long-term care. Most have lung diseases like COPD, and they have heart disease and those sorts of things, and cancer. And so PSWs are involved in all these illness journeys that limit life. Thanks for sharing that poll with us. It highlights your expertise and how you're caring for these individuals. And so you are palliative care experts. You are already palliative care experts. We want to grow your knowledge and expertise as well. In your experience of what individuals living with life-limiting illness, what is it they want? I'm going to ask you to quickly put in the chat, and I'm going to carry on. I'm just going to briefly touch on it because I really want to hand over to Diane so that we can carry on with the time that we have remaining. And if we could just quickly go to the next slide following this one, the I wish slide. Thank you. What we certainly know is that individuals, as they're journeying along this life-limiting experience, is what they tell us is they want us to know them, see them, hear them, listening to them, respect them. They want people who are spending time with them, who they can trust, and they gain confidence in the care that they're going to have at the most vulnerable times in their illness journey. They want to make sure that we hear them, that we're actively listening, that we're always returning dignity and control wherever possible. They want to see that team work seamlessly together. That's how they feel the safest. We hear most often individuals want to die peacefully in their sleep, right? And in order for us to be able to facilitate that happening, it's the palliative approach to care that's seamlessly applied, that not only takes care of the physical, but takes care of the emotional, the legacy building, the suffering, that whole experience. In order for someone to die peacefully, it takes that holistic approach to address every need. They want to control what they can control, fix what can be fixed, dignity always incorporated in their care, right? They want to live until they're not. That's why our approach is life affirming. And they want to know that their team is knowledgeable and skilled. And with that, it's important that everyone knows that the PSW is uniquely positioned and plays a critical role in the palliative approach to care. And with that, I'll hand it over to Diane.
Thank you, Tracey. So next slide, please. I just wanted to, before we get into this slide, I wanted to acknowledge that when we're saying the word PSW or personal support worker, we know that some of you attending today may have other titles like a healthcare aide or an attendant, and there's many others. It looks like the many provinces are now aligning with the term PSW, but when we use that term today, we mean it to apply to many of the roles that you're doing. So next slide, please. So Tracey has already alluded to this, like you guys are really the first responders. You are an early warning system of client changes and needs, even of those that may be very stubborn. You're the eyes and ears of the interdisciplinary team. You guys know people on a very intimate level. You're involved with activities such as feeding and bathing. You spend the most time with the person. You see the person from top to toe. You're interacting with family members that other team members maybe never come across. So you know the individual very well. Next slide, please. So here's the many members of the palliative care interdisciplinary interprofessional team. And we just want to highlight, if we can just click on this. Yes, thank you very much. So we want to just really highlight, as Tracey has done, that the PSW role is as equally as important as other roles on the care team. Each member of the care team brings something unique to the individual's situation, but you guys really are the eyes and ears, and you can be in your capacity and we really encourage you to understand the roles and responsibilities of these team members, and we know there's a lot, and then that way you can advocate for other services or other needs that the client or the patient may have or the individual may have. So Tracey, I think we're just going to bring you back in, and I just wanted you to walk through the story you told us earlier last week about your sister's experience with the PSW.
Oh, thank you, Diane. I'll try and make this really brief. My sister was end of life because of ovarian cancer, and I was one of her primary caregivers. And we had gone through different members on the team that she wasn't feeling that she had confidence and trust in. And I was getting tired. I needed help. I needed support. And we got that. And the interesting thing is both her and her husband were highly resistant. They didn't want anybody else involved that other than the doctor and me. And then we were able to find a visiting nurse. And then we needed more hours and someone who's really good at end of life care in her instance. And she was very resistant. And we were able to get her to agree to try, just meet this person. And they sent a PSW who was dedicated to end of life care. And from the moment my brother-in-law answered the door, I could see his body relax. It was the way she introduced herself. It was how she moved. It was everything about her in her PSW role. You could feel her expertise the minute she walked in the room. And within 2 minutes, this lady, as a PSW, inspired more confidence and safety and gave me the relief I needed. That's the difference skilled PSWs make. And she was involved all the way through the rest of my sister's journey.
Thank you for sharing that very intimate story, Tracey. Thank you. Next slide, please. So just introducing this slide, and if we can just bring up the right hand of the screen, please. Thank you. So here's the 3-step framework for each role, which includes the PSW. I'm not going to spend very much time on this, but identify and screen, observe and assess, and we know that PSWs largely in their role, you're observing for changes, and plan and manage. So on the next slide, we're going to be showing you some screening tools. This is a very busy slide. We're not here today to teach you about how to use these slides, but or these screening tools, but in LEAP PSW, you would be introduced to them on a more in-depth level. I think for myself, having taught in the PSW program, if you're going to take a gem away from this slide, it's the stop and watch acronym there on the left-hand slide. So if you're scrambling now to track and write that down, remember you're going to get the slides emailed to you next week. So competency development, we've talked a little bit about LEAP Personal Support Worker, which is a new educational program that Pallium has just introduced in the last couple of months. I know at the agency I work for, we have had several people to take it. So it's really focusing on ensuring that you are able to build, as Tracey said, on what you already know, to be able to prevent very confidently as a member of the interdisciplinary team. So the LEAP Personal Support Worker, it is designed for you. It was designed by people that live and work in Canada. So we know it's a Canadian-based product, and it's going to assist you to build your knowledge and understand how to transfer that knowledge into your everyday practice. Next slide, please. So we want to move into our case study. So we're going to introduce you to Nick. Next slide, please. But just before we do that, thinking about your role as a PSW, what is the important first step in building a therapeutic relationship with an individual who has a life-limiting illness? And at this time, I'd like you to take an opportunity to put some comments there in the chat. So here we've got Elizabeth saying, get to know them as a person and not just their illness, listen to their story. And that's exactly what I'm looking for. I remember when I was first nursing, one of the best lines one of my mentors told me was to say something like this, and you may have to rephrase it for yourself, is I would say, what are some of the most important things I need to know about you to take care of you in the best way? And this really helps build confidence and creates a really good initial step into that new relationship. Next slide, please.
There's some beautiful parts in there. You guys are nailing everything because I'm seeing those keywords: trust, building the trust. Yes.
So we'll introduce you to Nick. He's a 77-year-old Cree gentleman living in a retirement community. He was never married, has no children, and was raised in a remote rural community, but he moved to the city to be closer to the healthcare team involved in his care. His medical history includes osteoarthritis, heart disease, type 1 diabetes, kidney disease, heart disease, with episodes of angina. Right now, he's independent with all his ADLs, IADLs, and he manages his own medications and healthcare appointments. Next slide, please. So over the past few months, Nick has seemed depressed and withdrawn. His appetite has decreased. He has episodes of nausea, and he is losing weight. I feel full so quickly, and nothing tastes good anymore. So what is your role in Nick's care? And put into the chat any concerns, needs, or observations that stand out to you. So first of all, let's ask, do you feel that Nick is appropriate for a palliative care approach at this time, with what we know at this point? And Elizabeth is jumping in to say, yes, she is, and that's the correct answer. So the second question I have for you is, what is important to know about Nick for you to provide holistic care? And yes, Marianne has said she's identifying spiritual and mental issues he might have. Brandy wants to know, have there been changes with why he isn't eating? How is his mental health? Excellent. Know his history. And yes, and we're talking about his history. What kinds of things do we want to know about? Yes, that's a very good point, Michelle. Loneliness, because we've said he's moved from a different community. So some of the other things we might want to be thinking about is his Cree values, his beliefs, and his traditions. And Marianne, yes, she's bringing that in as well. We want to be culturally sensitive. Excellent. Next slide, please. So last week, Nick went to the emergency room because he had a sudden episode of very severe pain. He was admitted to the hospital and had a full investigation, and his diagnosis was pancreatic cancer. He's not a candidate for surgery. He declined chemotherapy, but is going to have radiation therapy to assist with his pain and symptom management. He has been discharged back to his retirement community. So what are your thoughts now? For your role as a PSW, with knowing this new information, what is going to be your role? Thinking about some of the slides that we've had with Tracey and I up until this point. Yes. So I'm probably not going to pronounce your name right, but I'm going to say Adedeo is suggesting palliative care. So what do we mean by that? We did define that, but what are some of the steps we might be thinking about? We briefly introduced you to some of the screening tools. So we're going to identify and we're going to screen. What are some of the things we might screen for? So Emmanuel is saying make him more comfortable. So maybe you're alluding to symptoms such as pain. Pain management, yes. One of the things as the PSW, you would be observing for any signs of functional decline. Any other changes that you might be watching for? Weight loss, yeah, we're going in the right directions now. Thank you, Michelle. Cognitive decline. I think given the fact that he is a type 1 diabetic, we might want to watch for signs and symptoms of fluctuating glucose. Emotional and spiritual health, fluid intake, diet. Excellent. You guys are totally on the right place, going in the right direction. What about planning and managing? What do we have to be looking for? Planning and managing, thinking about in the next month, in the next few weeks. Here we're thinking about what is his preferred location of death. Does he want to perhaps return to his remote village? Are there other people from his Cree nation that we can bring in to be involved with his care? Are there traditional medicines that maybe he wants to include? Next slide, please. Sorry. Does anybody else have any other comments about Nick? I think what we were trying to demonstrate here is, again, going back to the PSW being the first responders. In this particular situation, I'm sure many of you who have identified that you work in a retirement community or community care are probably very aware that you would be the person that would be spending the most time with Nick. You would be part of the community that would be his eyes and ears, and you know, making those connections to other team members that can help him in his final journey. So we're quickly running out of time. It's quite surprising on how fast these sessions can go. Did you see any pearls in the chat there, Tracey?
I am. I'm seeing that there's a lot of pearls, and that I'm seeing from different participants that they're hitting some of the targeted different hot button things that would be important around Nick. I think that when I do a summary of what I'm seeing from the chat is Nick was palliative from the moment was appropriate for a palliative approach to care from the moment that Diane introduced, because he had heart disease. He had things that were life limiting. He didn't just need a palliative approach to care when he was diagnosed with cancer. He was already for quite a long time. And I wonder who picked up on the fact that he became depressed, and who picked up on the fact that his appetite wasn't so good, and who picked up on the weight loss. It was most likely the PSW that was involved in his care. And as things were progressing, it's your eyes observing, screening, reporting those changes, not just the physical, but the psychosocial, emotional, and spiritual. You know, the interesting thing in this specific case, and I'm just going to add this quickly, because it's important as PSWs that you're asking the rest of the team what's important for us to know in order to watch, observe, and report. And in pancreatic cancer, you know, the very first symptom we often see is depression. And Nick had that, the depression, and he was feeling full quickly. Yeah. So there are those warning signs. We just need to learn what they are, to watch for, so we know how to report and galvanize that team to action. Good job.
Thanks, everybody. So we just have one final poll. After completing today's session, do you agree with the following statement? PSWs are integral to care of individuals and families living and dying from a life-limiting illness. Because PSWs are often the first care team member involved and spend the most time with them and their family, they can provide unique insights. PSWs are the eyes and ears of the care team.
We're seeing 100%.
Excellent. So just in wrap up, there is a feedback survey after the session, which we would greatly appreciate if you could fill out. Reminder, you will get a recording of the session that will be emailed to you next week. Watch for the registration links for the July and August sessions. We would be delighted to see you. Next slide, please. And we referred to LEAP personal support worker several times. Not sure if Gladys is on the call and if she wants to jump in just for a quick minute. Gladys is a team member of mine who has completed this program. So if Gladys is there, you can raise your hand. Hi, Gladys. You can just unmute yourself there, or maybe I have to. Pallium might have to do that for you.
Yeah, I'm here.
Hi, Gladys, welcome. So can you tell us how you found the course?
Oh, it was good. I was listening since you began. It was okay. It was good. And
Yeah.
now you're talking about the thing. I have a client, the same position now, who just diagnostic, and then the thing began. This morning I just say to the people in the retirement home to observe her breathing is not the same anymore.
Okay, so that's great. So you're telling me that you're actually able to utilize some of the training and information that you received in the PSW. That's excellent. Thank you so much. And would it take approximately 10 hours to complete?
Pardon?
It's fine. I think we're kind of like running out of time, and I think your internet connection is not quite great. But thank you very much, Gladys. Jeff, did you want to speak to this, or Pallium? Thanks, Jeff.
Sure. Yes. So can everyone hear me okay? All right. I'm assuming so. Thumbs up. All right. Well, first off, Diane, Tracey, thank you so much for sharing your collective knowledge on such an important topic, and couldn't agree with you any further. The PSWs play such a critical role on healthcare teams, and it was nice to hear that, and for Tracey to share some of your personal stories as well. It was a very riveting session. I want to let everyone know that there's an upcoming session that's opened up for registration. It's called Taking Vitals, the SCQ, the Evidence, Development, and Clinical Necessities of a Measure to Routinely Assess Patients' Experiences of Compassion. So that's happening on Tuesday, June 29th from 12 to 1. So if this is something that would be of interest to you, please register at echopalliative.com. We'd love to have you part of that webinar. Again, thank you to our two presenters. Thank you all for taking time out of your busy schedules and being part of this and contributing to the dialogue. A very, very rich conversation and dialogue that ensued, as I saw throughout the chat conversation. So thank you. All the best, and have a great rest of your day. Take care.